This is a critical alert for every veteran relying on the Department of Veterans Affairs healthcare system. We need to talk about 2025. This isn't just routine maintenance. This is a seismic shift in how veterans access care, and if you live near one of the 10 facilities currently slated for closure, or even just significant realignment, the time to prepare is right now. Don't wait until the doors are locked. The system is changing, and while the VA promises better, more modernized care, the reality of transitioning thousands of patients overnight is messy, complicated, and frankly, often leaves the veteran feeling lost. This closure list isn't final, but the wheels are in motion, driven by the VA's Comprehensive Asset and Infrastructure Review, or AIR Commission recommendations. A massive effort to modernize old, often dilapidated buildings and shift services closer to where veterans actually live today, which often means moving care out of large, centralized, outdated hospitals and into smaller, community-based clinics. But what happens when your local clinic, the one you've relied on for years, is on that list? What happens when your established primary care provider is suddenly 90 miles away? That's the core concern we tackle today. We're not just going to panic, we're going to arm you with a 5-step action plan to ensure your healthcare continuity remains unbroken, guaranteed. The fear surrounding these closures is completely justified. For many, the VA clinic isn't just a building, it's a lifeline. It's where trust has been built over decades, where specialized care for service-connected disabilities is managed, and where accessibility, especially for older or disabled veterans, is paramount. The closures, which are strategically targeted at facilities deemed underutilized, geographically misplaced based on current veteran populations, or simply too old and expensive to maintain, are intended to funnel resources into new, state-of-the-art facilities, or, crucially, into the community care network. But the transition period is a minefield. Many veterans have already experienced the chaos that comes with major system overhauls. We have to be proactive. We need to cut through the bureaucratic fog and figure out exactly what you need to do today to safeguard your health tomorrow. The critical difference between a smooth transition and a lapse in life-saving care often comes down to 5 specific, actionable steps you must take immediately. The first and most foundational step you must take if you hear whispers or confirmation that your local VA facility is on the chopping block is to verify your status and confirm the transition plan. Panic is the enemy of preparation. You need hard data. Don't rely on rumors you heard in the waiting room or a single local news report. Go directly to the source. The VA is required to communicate these changes, but often that communication is buried in dense mailers or confusing online portals. Your immediate mission is twofold: confirm the closure date and identify the designated receiving facility. This information is usually managed at the VISN, or Veterans Integrated Service Network level. Start by calling your current primary care clinic directly. Ask them, what is the official closure date and where are my records and future appointments being transferred? Demand specificity. Do not accept vague answers like somewhere nearby. You need the address and the name of the new facility. This verification process is crucial because sometimes a closure means the main building is shutting down, but services are being dispersed into multiple, smaller, specialized community clinics rather than consolidated into one massive new hospital 100 miles away. Understanding the exact transition model, consolidation, decentralization, or pure community care outsourcing will dictate the remaining 4 steps you need to take. If you are unable to get clear answers from your clinic staff, escalate the inquiry to the patient advocate at your current facility. They are specifically trained to handle patient rights and transition concerns during these periods of systemic change. Furthermore, if you are a specialty care patient, perhaps managing complex cardiology issues, oncology treatments, or high-level physical therapy, you must confirm that the specialist you rely on is moving to the same location as your primary care, or if that specialty service is being completely outsourced to the community care network. A failure to confirm the continuity of specialty care is the #1 reason veterans experience dangerous gaps in treatment during these facility transitions. You must track your specialists like a hawk. This verification process is tedious, yes, but it is the foundation upon which your continued health care rests. Now, let's talk about the second absolutely vital step, which is the key component of modernization and the primary destination for services displaced by these 2025 closures. Master the Community Care Program, CCP. For decades, VA care meant being seen inside a VA facility. The Mission Act fundamentally changed that, and these closures are accelerating the shift toward outsourcing care to private providers. If your clinic is closing, or if the new designated VA facility is simply too far, the Community Care Program, or CCP, becomes your new primary lifeline. But the CCP is not automatic, and it is not simple. You cannot just call a private doctor and expect the VA to pay. You must understand the eligibility requirements and the authorization process. There are 6 main eligibility criteria for community care, and distance is the most relevant one here. If the closure of your clinic means that your drive time to the nearest full-service VA facility exceeds 30 minutes for primary and mental health care or 60 minutes for specialty care, you are automatically eligible for community care. However, eligibility is useless without authorization. Every single visit, every referral, every prescription refill through a private provider must be pre-authorized by the VA. If you skip this step, you will be left holding the bill, and fighting the VA retroactively is a nightmare you want to avoid at all costs. Your action item here is to establish a relationship with the Community Care Office at your VISN immediately. Do not wait until your clinic closes. Start requesting authorizations for non-urgent care now, using the distance criteria, even if your clinic is still technically open. This serves 2 purposes. It gets you familiar with the authorization process, and it establishes a paper trail showing your reliance on community options due to impending geographical hardship. Furthermore, you must maintain impeccable records of every authorization number, the date it was issued, the specific service approved, and the name of the authorized provider. The CCP system is notorious for communication errors between the VA, the third-party administrator, TPA, often TriWest or Optum, and the private provider. You are the only person holding all 3 parties accountable. If your clinic is closing, mastering the CCP is not optional. It is the essential administrative skill you must acquire to maintain your health coverage. This mastery extends to understanding the specific forms required for appeals if your community care request is denied, such as the Notice of Disagreement process, which is often necessary when the VA wrongly calculates your distance or wait time eligibility. This whole process, from initial request to final authorization, can take weeks, sometimes months, and that delay is precisely why preparation is necessary. Before the closure date arrives, moving into the 3rd crucial step, and one that often blindsides veterans during transitions. Secure transportation and logistics. The VA might be moving your services 50 miles down the road, but they are often not automatically solving the logistical challenge of getting you there, especially if you have mobility limitations, rely on specialized equipment, or live in a rural area with poor public transit options. The closure of a nearby clinic means that your reliance on the Beneficiary Travel Program, BTP, will likely increase dramatically, and you need to understand its limitations and how to maximize its benefits now. First, ensure your BTP eligibility is current. This typically involves submitting VA Form 103542, but eligibility can change based on income thresholds or service-connected status. If you are 70% or more service-connected or traveling for a service-connected condition, your reimbursement is typically guaranteed. If you are not, the financial hardship criteria apply. When the new facility is significantly further away, the mileage reimbursement becomes critical, but it often does not cover the true cost of time, wear, and tear on your vehicle or the cost of gas. Therefore, your action plan must include investigating specialized VA transportation services. If you require wheelchair accessibility, oxygen, or attendant assistance, the standard mileage reimbursement is insufficient. Contact the BTP office at your new designated facility or the facility you're being transitioned to and inquire specifically about the Veterans Transportation Service, VTS. VTS provides dedicated transportation, often using VA vans or contracted services, to get veterans to appointments. However, VTS resources are limited and routes are often established months in advance. If your clinic is closing, the VTS routes in your area are about to be completely redrawn. You need to get on the priority list now. Furthermore, explore non-VA resources. Many veteran service organizations, VSOs, like the DAVI, Disabled American Veterans, run volunteer driver programs. These programs are often overburdened, but if your local clinic is closing, the VSO in your area will likely be ramping up volunteer recruitment. Establish contact with them today. Do not assume transportation will be available simply because you are a veteran. Logistical planning, including mapping out the least stressful routes, understanding peak traffic times to the new facility, and securing backup transportation plans, is a mandatory step to prevent missed appointments and dangerous gaps in care. Remember, a missed specialty appointment due to transportation failure can result in a 6-month delay in rescheduling, especially in high-demand fields like rheumatology or neurology. Securing logistics is securing continuity. The fourth step is focused squarely on preserving your ongoing treatments. Review and update all specialty care referrals. When a clinic closes, the administrative process surrounding existing specialty care referrals is the most common point of failure. The VA system is built on specific authorizations tied to specific locations. Just because you had an approved referral for physical therapy at the old clinic does not mean that referral automatically transfers to the new facility or, more importantly, to a community care provider. Your action plan here is mandatory administrative housekeeping. Pull every single active referral you have for mental health counseling, pain management, cardiology follow-ups, dental work, whatever it may be. Cross-reference the referral number, the expiration date, and the authorized location. If the authorized location is the clinic that is closing, you must initiate the reauthorization process immediately. Call your current primary care provider, PCP team, or the team they are transitioning to, and explicitly state that you need a new authorization for the continuation of Service X at the new location Y. Do not assume this happens automatically. If your specialty care is being moved to the community care network, the process is even more complex. You need a new community care authorization, which means your PCP needs to submit a new consultation request to the TPA, TriWest Optum. This takes time if your current specialty appointment is scheduled for, say, March 2025, and your clinic closes in January 2025, that March appointment will likely be canceled unless the referral and authorization are updated before the closure date. The key concept here is proactive renewal. For mental health care, this step is particularly critical. Disruptions in mental health services can be catastrophic. If you are seeing a counselor or psychiatrist at the closing facility, ensure that your established relationship can be maintained either through telehealth options or by ensuring that specific provider is transitioning to the new location or the community care network. If the provider-patient relationship cannot be maintained, you must request a new referral to a provider who specializes in your specific needs before the transition occurs, allowing you time to establish rapport. Furthermore, this review must include your prescriptions. While prescriptions are generally systemic, if you rely on specialized medications managed by a specific clinic pharmacy, confirm the transfer process for those specialized drugs. Update all your emergency contact information and ensure the new facility has the most current list of all your medications, VA and private. A thorough review of your active referrals is the only way to avoid a lapse in critical ongoing treatment. Finally, the fifth step requires you to become an active advocate for yourself and your fellow veterans. Engage your VSO and local representatives. When systemic change like the closure of 10 major VA facilities occurs, individual complaints often get lost in the noise. Collective advocacy, however, can force accountability and clarity. Your action item is to connect with your accredited Veteran Service Officer, VSO, immediately. This could be through the DAV, VFW, American Legion, or state VSO offices. They are not just for claims. They are experts in navigating the VA bureaucracy, and crucially, they have direct lines of communication with VISN leadership. Inform your VSO that your clinic is closing. Detail the specific problems you're facing, e.g., lack of transportation, confusion over community care authorization, loss of a specific specialist, and ask them to intervene. VSOs track patterns of failure. If dozens of veterans are reporting the same difficulty getting community care authorized due to the closure, the VSO can elevate that systemic failure to the regional director, forcing a resolution. Beyond the VSO, you must engage your elected officials, your congressional representative, and your 2 senators. The VA is ultimately accountable to Congress, and nothing motivates the VA to fix a problem faster than an inquiry from a congressional office. Write a concise, factual letter outlining your concerns about the clinic closure, the impact on your health, and the specific lack of clarity or resources you're experiencing. Congressional staff members have dedicated VA liaisons who can cut through the red tape that would stop an individual veteran cold. They can inquire about the specific timeline for the new facility construction, demand clarity on the community care funding allocation for your area, and ensure the VA is meeting its legal obligations under the Mission Act to provide timely and quality care. Remember, these closures are often highly political, driven by infrastructure budgets and population shifts. Making your voice heard through political channels is not complaining. It is exercising your right to demand the care you earned. Furthermore, consider joining or starting a local veteran advocacy group focused specifically on the transition. Collective action ensures that the VA does not simply sweep the problems under the rug. This engagement step is about utilizing the full power of the veteran community and political oversight to ensure that the transition is managed with competency and respect. Let's expand on the administrative quicksand that is the community care program, because this is where the majority of displaced veterans will land, and this is where most mistakes are made. The VA's goal is to make community care seamless, but the reality is that it involves 3 separate entities: the VA itself, the third-party administrator, TPA, and the private provider. Communication breakdowns between these 3 are rampant. To truly master the CCP, you must understand the concept of the authorizing entity. When your clinic closes, your authorizing entity shifts. It is no longer your local clinic staff casually placing a referral. It becomes a centralized authorization team, often hundreds of miles away, relying solely on digital records. This centralization often leads to denials based on incomplete information or bureaucratic misunderstanding. For instance, if you have a service-connected condition like PTSD that requires specialized therapy, the centralized team might deny the community care request because a general VA psychiatrist is technically available 75 minutes away, even though the specialized therapist you need is only available privately and locally. This is where the appeals process becomes essential. When you receive a denial for community care, you have the right to challenge it, usually starting with a Notice of Disagreement, NOD. This nod must clearly articulate why the denial violates the standards of the Mission Act, specifically citing the distance criteria, the wait time criteria. If the VA cannot schedule you within 20 days for primary care or 28 days for specialty care, or the best medical interest criteria, do not let a denial stop you. Use your VSO to help draft the nod, as they are experts in the specific language required to overturn these administrative roadblocks. Furthermore, we must talk in depth about the specific types of closures that are happening in 2025 and how they affect different groups of veterans. The 10 facilities targeted are not uniform. Some are massive, historic medical centers, VAMCs, where the entire system is being moved or consolidated. Others are smaller, community-based outpatient clinics, CBOCs, located in rural areas. If your VAMC is closing, the disruption is immense because complex services like surgery, inpatient mental health, and specialized imaging are being relocated. If you rely on these high-level services, you must confirm the receiving facility has the capacity and the specialized equipment to handle your needs. For example, if you rely on a specific type of radiation therapy available only at the closing VAMC, you need written assurance that the replacement facility has the exact same machine, or that a community care authorization for that specific high-cost treatment has been secured. If your CBOC is closing, the primary concern is distance and the loss of familiar local primary care. CBOC closures disproportionately affect older veterans and those with significant mobility issues who rely on the short drive for routine care. In this scenario, the transition must lean heavily on telehealth services. Your action plan should include verifying your eligibility for VA-provided telehealth equipment, such as tablets or internet access subsidies, if you live in an area with poor connectivity. The VA is required to bridge the gap created by geographical distance, and telehealth is a primary tool for that. Demand a telehealth consultation with your PCP before the clinic closes to ensure the technology works and you are comfortable using it. Let's circle back to transportation, because the complexity here is often underestimated. When your clinic closes and your travel time increases, the sheer volume of veterans applying for beneficiary travel, BTP, reimbursement skyrockets, leading to massive delays in payment. Veterans often wait months for checks, creating a real financial burden. To mitigate this, you must meticulously document every single trip. Keep a detailed log, date, time, mileage, using a consistent mapping service like Google Maps for documentation, and the purpose of the appointment. Submit your claims electronically through the Beneficiary Travel Self-Service System, BTSS, whenever possible. Paper claims are notoriously slow. If you are struggling with the financial gap, you need to communicate this to the patient advocate. In extreme cases of hardship related to travel costs for service-connected conditions, the VA has limited discretionary funds that can be accessed, but this requires significant advocacy and documentation of the financial strain. Do not suffer in silence waiting for a BTP check. The logistical nightmare of increased travel distance also extends to the time commitment. If you had a 15-minute drive for a 30-minute appointment, and now you have a 90-minute drive each way, that is 3 hours of travel time for a short appointment. This time commitment affects employment, family care, and quality of life. When appealing a community care denial, you can use this excessive time burden as evidence that the VA care is not reasonably accessible, even if the distance criteria are technically met. The burden of travel argument is a powerful tool in your advocacy arsenal. We must also dedicate significant time to the importance of the patient advocate during this crisis. When a facility is closing, the patient advocate's role shifts from resolving minor disputes to managing mass patient displacement. They should be your first point of Contact after your initial call to the clinic staff fails. They are the internal watchdogs. When you contact them, be concise and professional. Do not vent. State the problem and the desired resolution clearly. For example, problem: my specialist, Dr. Smith, is leaving the VA due to the closure. Desired resolution: I need immediate authorization for community care with a comparable specialist in the local area. Pre-approved for 6 months of follow-up. If the patient advocate is unresponsive or overwhelmed, that is when you escalate to the VISN patient advocate, who oversees the entire regional network. If the VISN advocate is also failing, that is the moment you contact your VSO and your congressional representative, providing them with the names and dates of your attempts to resolve the issue internally. Documentation of the patient advocate's failure to assist strengthens your case when seeking external intervention. Remember, the patient advocate is there to ensure your rights under the VA system are protected, and continuity of care during a closure is a primary right. Let's delve deeper into the administrative requirements of transferring your medical records. While the VA system is electronic, Vista CPRS, the transfer of records during a closure is not always flawless, especially if you have significant paper records, external records from non-VA providers that were manually scanned, or specialized diagnostic images like complex MRIs or CT scans. Your action plan must include obtaining a personal copy of your most critical records before the clinic closes. Use the My Healthy Vet portal to download your Blue Button report, which contains your appointments, medications, allergies, and basic clinical summaries. But go further. Request a full copy of your medical records for the past 5 years, focusing specifically on records related to your service-connected conditions. This request should be made to the Health Information Management (HIM) department at the closing facility. Having a physical or digital copy of your records serves as an essential backup. If there is an administrative delay in transferring your electronic file to the new facility, you can provide the new provider with your copy, preventing a dangerous delay in treatment. This is particularly important if you are transitioning to community care, as the private provider will need a comprehensive history, and the VA is often slow in transmitting this data to external entities. Do not rely solely on the VA's electronic system. Assume administrative failure and prepare your backup. Another overlooked area during facility closures is the impact on caregiver support. Programs. If you are enrolled in the Program of Comprehensive Assistance for Family Caregivers, PCAFC, or any other VA caregiver support program, the closure of your local clinic can impact your required interactions, training sessions, and local support groups. Caregiver support programs often rely on local VA staff for check-ins and training modules. If the facility closes, you need confirmation that the new designated facility or the local caregiver support coordinator is aware of your enrollment and that your required training schedules will be maintained, either through virtual platforms or at the new, potentially distant location. A disruption in caregiver support can destabilize the entire care structure for a severely disabled veteran. Contact the caregiver support coordinator at the closing facility immediately to confirm the continuity plan for your specific case. Finally, let's look at the financial implications beyond travel reimbursement. When a major VA facility closes, there is often a ripple effect on local veteran employment. Many veterans work at the facilities they use for care. If you are a veteran employed by the closing clinic, your employment status adds another layer of complexity to your healthcare transition. You need to understand your rights regarding job transfer, relocation assistance, and how your employee health benefits, if separate from standard VA care, will be affected. This is a specialized scenario, and you must contact the VA's Human Resources Department alongside your VSO to navigate the employment and healthcare transition simultaneously. The stress of losing a job combined with the stress of losing your healthcare facility is immense, and specialized support is necessary. In summary, the 2025 VA clinic closures, while framed as modernization, represent a significant challenge for veterans who rely on established, accessible care. The transition is not automatic, and administrative errors are guaranteed. You must adopt a mindset of proactive defense. Remember the 5 critical steps. First, verify your status and confirm the transition plan. Know the closure date and the receiving facility. Second, master the Community Care Program, CCP. Understand authorization, distance criteria, and the appeals process. Third, secure transportation and logistics. Maximize BTP, investigate VTS, and plan your routes meticulously. Fourth, review and update all specialty care. Referrals. Reauthorize every active treatment plan before the doors shut. And fifth, engage your VSO and local representatives. Use collective advocacy to force accountability and clarity. Your health is too important to leave to one more bureaucratic chance. Start preparing today, document everything, and do not accept a lapse in the care you earned. The VA system is designed to serve you, but during periods of mass transition, you must be the one driving the process, ensuring your continuity of care remains the absolute highest priority.